Good evening, everyone. I'll give everyone a second just to connect to audio, and then I will get us started. So nice to see everyone this evening. All right, so thank you so much for coming to tonight's ECHO session. This is the role of immunotherapy in advancing the treatment of HCC and BTC. This session is titled The Importance of a Multidisciplinary Patient-Centered Approach for Optimizing the Care of People with HCC. I'm Sarah Bingle McKillips. I'm with the France Foundation, and I'll be your staff host for tonight's session. Again, it's wonderful to see you all here this evening. Before we start, if you are new to the ECHO project, I'll just take a brief moment to explain the premise behind our meeting format. Project ECHO stands for the Extension for Community Healthcare Outcomes. It's a global movement to share knowledge and expertise across distances, creating a learning loop where all the participants, including our panelists and you, can learn from one another. All the sessions are designed to be interactive, so we really encourage you to make the most of our time by asking any questions you have about your HCC or BTC cases. Your active participation really makes these sessions invaluable. So again, thank you so much for being here tonight. I'm looking forward to our session, and I'm going to hand it over to Dr. Pillai to get started.
Thank you, Sarah, and thank you everyone for coming. So we will get started. Next slide, please. All right, so we already said that this is going to be really focusing on multidisciplinary patient-centered approach. We wanted to really dedicate a session on this because we truly feel that this is how HCC should be practiced, or biliary tract cancer should be practiced in all settings, not just academic. So whether we're in community settings, academic, really ideally having a multidisciplinary group approach is optimal. Next. I'll just introduce myself and have my colleagues also introduce themselves. So my name is Sanjana Pillai. I'm a transplant hepatologist at the University of Chicago. Joseph.
Good evening, everyone. Joseph Francis. I'm a medical oncologist at the University of Chicago.
Hi, everybody. My name is Osman Raz Ahmed. I'm an interventional radiologist at the University of Chicago.
All right, and our planning committee is on the right-hand side. Next slide, please. These are disclosures. Next slide, please. So as far as accreditation and credit designation, we do offer ACCME, ACP, and ANCC. So you get one CME or ACCME hour for this program. The educational activity is supported by a educational grant from AstraZeneca. And if you're really curious about the full syllabus is in that link right there. So the session objectives today, again, just develop strategies for effective multidisciplinary communication and coordination. 3 ways that we'd ideally do it. 1, to recognize how multidisciplinary communication and coordination can improve patient care. Identifying key elements of effective multidisciplinary patient-centered care. And then considering multidisciplinary communication and management approaches to improve patient care and how best to implement those practices. So when you think about multidisciplinary teams, there's a couple of, goals. So the primary goals really should be to facilitate communication between specialists so patients are not seen in silos, to provide individualized and optimized care for diagnosis, treatment, and outcomes. And there's several models, and it really depends on your institutional resources and expertise available. So some places only have a multidisciplinary tumor board, and it may be pancreaticobiliary and hepatology, or there might be a separate surgical oncology, pancreaticobiliary and hepatobiliary. Other places have very fluid referral systems between specialists, so not necessarily a co-located clinic. And then our places like ours, we have co-located clinics with multiple specialists that can see the patient concurrently at the same time on the same day, and also have multidisciplinary tumor boards, which should meet at least once a month, if not weekly, depending on your volume. Next. So when you're looking or when you're talking or discussing about a patient's case, the most important thing really is to determine the best treatment for each patient. And one of the first things that we always talk about is there a curative option for this patient? And if there is not, then what are the next best ways to get to a potential curative option or long-term survival while preserving quality of life? So you have to think about the size and number of tumors, where the tumors are located, whether or not the patient has preserved liver function or has more advanced liver disease. The physical well-being or ECOG status or performance status of the patient is very, very important. And then, of course, figuring out which staging and treatment guidelines that you want to use. Next. And clear benefits of MDTs, in the beginning, there wasn't as much data, but over the last 20 years, more and more data have shown in multiple cancers clear benefit of MDTs, including in HCC. And so multidisciplinary teams are associated with recommendations for guideline concordant treatment, higher rate of curative treatment receipt, and significantly improved overall survival in a large meta-analysis. Next. And other potential advantages. So again, multidisciplinary perspective, right? So you have the ability to use a full cohort of specialists and their expertise to enhance treatment discussions. There's more than just imaging and biopsy results, and also increase center-wide awareness of HCC. So really making not just, one specialty understand the importance of surveillance, but we all understand that early surveillance leads to curative option and early detection. And it also leads to, sorry, go back one, please, better care coordination as treatment options increase. So as we have really changed our landscape for HCC, before there was one systemic therapy option available, which is sorafenib, and mostly it was TACE. If you didn't have surgery, it was either sorafenib or TACE. And that really has now exploded into multiple multimodal therapies, combination therapies. So now you have a greater need for communication between providers so patients don't get lost in the transitions between care. And it's also helped to facilitate recruitment for studies, so for research on optimal care and combination treatments. Next. So elements of a multidisciplinary team, you really do need institutional support. You have to identify your core providers. So who are your specialists in each, who are your core provider, each of the specialists that are going to participate in not just a tumor board, but also in your clinic. You do need operational components. So you need to think about marketing, clinic structure, clinic space, outreach. You do need administrative support. A nurse navigator is really, really important in these clinics and have a very pivotal role, specifically when preventing gaps and transitions of care. And then how are you going to communicate and integrate the recommendations that the team makes? So ideally, you should have a medical record electronic medical record pathway to communicate the information so that, and then ensuring that it does get carried out. Next. So who is involved in an HCC MDT? Again, as I said, it is a pretty resource heavy ask, but it's also one of the easiest business plans to ask because, again, with treatment of HCC, almost every specialty does have downstream revenue, which actually directly affects patient care and optimizes patient life, ideally. So you have radiology imaging, you have infusion from chemo, you have interventional radiology, you have surgery, you have transplant. So really it is a pretty easy business plan for the hospital to understand the importance of this. The big ask that there might be some issues with is asking for a nurse navigator or coordinator. But once you realize that, if you're not losing patients through these transitions of care and you're keeping them and giving them long-term survival, it actually is also pretty easy to show that. So you do need a nurse navigator or coordinator. You do need someone that specializes in liver disease, so hepatologist or gastroenterologist that specializes in liver disease. Ideally, you should have palliative care specialists, which we've recently incorporated into our tumor program, dietitian, nutrition, social workers, which often the cancer center also has available. And then you need, your core components. You need your medical oncologist, your interventional or radiation oncologist, your transplant or hepatobiliary surgeon. You also do need an expert abdominal imaging radiologist, which is not on here, but that's very, very important, often runs the tumor boards as far as reviewing imagings. So again, standardizing operational pathways are really important. Understanding which staging systems you're going to use is really important. And if you are part of a large center such as UFC, it's also important to figure out how we can extend to our satellite clinics as well and to provide essential services to other areas. So inter-institutional cancer clinic and external liver tumor boards are really, really an important part of it, which we're still working on some of those. Next. So when you look at care providers, we already kind of talked about the patient's always in the center. We're always thinking about what benefits the patient best, and ideally, and always the patient should be part of their care and informed of the decision making and agree to it. But again, many touch points. You have primary care, your hepatology, your gastroenterologist, oncologist, radiation or interventional oncology, palliative care, surgery, pathology, other support groups. So there's so many patients, so many touch points for the patients. This is also where nurse navigator is very, very important. And really the idea of the MDT is to focus on evidence-based clinical decisions and coordinate care delivery at all stages, from very early stage to advanced stage, including palliative care. Next. As far as the role of administration, administrative support, this is where we talk about resource heavy. You really should you need someone to intake these patients. You should have an idea of who you want to see in your clinic. You need to make sure your clinic is not backed up. So as soon as you start the clinic, there's not a 6-month wait. It's cancer, so ideally 1 to 2 week wait, and kind of prioritize who needs to be seen urgently. So that's where the administration comes in: support and resource allocation, participation in planning and integrating workflows, and again, and documentation and communication. Our nurse navigator and our administrators from both transplant and the cancer center, as well as our interventional radiology colleagues, we all have nurse practitioners and administrators that work together to get our patients in through these programs. Next. And when you're operationalizing these things, it is very important to have regular meetings. So at minimum, they should be once a month. We meet weekly because of our volume. Some places meet even twice a week. So it's very important to have regular meetings. And then the second is the standardized forms. We don't have in our center, we don't have a true standardized form, but we do have more or less a quasi form where you need to kind of give pertinent highlights of why you're presenting the case, right? No one has time to go through the electronic medical record while we're doing a tumor board. So you need kind of an idea of who the patient is, why we're seeing them, what their liver function is, what their tumor markers are, and what's the question being asked. So that's very important. And then afterwards, a documentation of what we found. So we send our documents out every week, usually within 24 to 48 hours, to the group at large. And our nurse navigators put that into Epic. And then ideally, MDTs should also meet regularly, either once a year, twice a year, if there are changes in the landscape, new trials, to make sure that you're offering best practices. And also our MDT offers a CME, so that's another thing you can do. That way, the hour that you're there, people are also getting a CME for it. Next. Is this Joseph or is this still me?
I think I can take over. Yeah, no problem. Yeah, so thanks, Dr. Pillai. So I think the major message that Dr. Pillai has been emphasizing is the system is kind of critical to kind of ensuring the smooth functioning of this group of people. And so, kind of the appropriate operational pathways that are kind of data-driven and guideline supported are critical here. So these guidelines and protocols can apply from all spectrums of the whole spectrum of the cancer kind of process, from diagnosis to staging to initial treatment options, hopefully leading to some definitive or curative intent surgical procedure followed by postoperative surveillance, but could be that we're kind of, even for patients who don't make it to these kind of final steps from left to right on here, hopefully they can still benefit from these pathways. Next slide, please. So part of the process, as Dr. Pillai mentioned, is kind of optimal documentation, and they're kind of the basic pieces of information that must be provided are, both staging, which includes the tumor burden, the liver function, and kind of the substrate, the patient kind of health and performance status. And then that can inform the treatment options. So again, ideally, we can optimize or maximize the patient who are able to ultimately get to a definitive intent, either surgery or liver transplant. But that's not a guaranteed process. But again, hopefully these optimal discussions will then lead the most number of patients to these. And finally, in the other direction, for patients with advanced stage disease, again, advanced care planning, contingencies that incorporate, patient kind of values and goals are also important topics of discussion at these multidisciplinary clinics. Next slide, please. So yes, so again, it's very important to follow the national and perhaps international guidelines for all stages of the cancer process. The multidisciplinary tumor boards can either be totally internal or primarily internal, let's say, but it's always good to collaborate with external boards as well, especially if you're a less resourced center. And again, the goal is to conduct regular evaluations of HCC and increasingly biliary tract cancer cases as well, and to establish protocols and then kind of regularly reevaluate kind of metrics of outcomes of patients evaluated in this setting. Next slide, please. Great, so yeah, so again, some of the benefits of these MDTs are improved communication amongst the team members, kind of within the groups, and also better communications to external providers or family members or foundations, et cetera. And then finally, since these networks are not always within the same building or campus, the incorporation of technologies like video messaging and telemedicine can really facilitate some of these discussions in a way that was not as easy 10 years ago. Next slide, please. Great. So again, here's some kind of tips. We don't necessarily have to go through all of them, all of the boxes of these kind of arrays one by one, but in general, all of these communication optimization tricks can be used at each phase of the process. Again, so a screening or detection phase, for example, we can work to help to educate the more generalists, like primary care docs or the frontline, medical specialists, about risk factors for HCC development and to whom the screening guidelines apply the most rigorously. That also applies to some more general gastroenterologists, although many GI doctors are very tuned in to these hepatology recommendations. And it also could mean improving communications with patients, including patients, for example, who, because they were successfully treated for their viral hepatitis, hep C, for example, may mistakenly think that they no longer need surveillance for HCC, which unfortunately is probably not consistent with guidelines. Next slide, please. And certainly later on in this process, again, during active treatment, again, ideally, we can help to facilitate within the network or within adjacent networks of providers, care options that are more convenient for the patients. For example, getting standard, immunotherapy infusions at satellite locations or with collaborating physicians at other institutions that are more convenient for the patient, closer to home. And also to, again, facilitate communication between other non-MD, providers as part of the team, like social work, nutrition, folks who help with navigating the difficulties with finances sometimes. These are all critical components of the team. And then finally, again, hopefully for patients who we are successful in getting to a curative intent operation, like a transplant, for example, how can we optimize the surveillance and post-treatment or survivorship plan? And how can we help to optimize their general health after they're done receiving cancer therapies? And then for the patients whose disease progressed, despite all these interventions, of course, to help to engage the other providers and team members who can help them with end-of-life care planning and discussions. That's critically important as well. Next slide, please. So we mentioned that telemedicine is a increasingly utilized and convenient method to facilitate these communications. Most tumor boards, I believe, that I'm aware of are done by Zoom meetings or team meetings these days, and that's a very convenient setting, but it also allows kind of expanded reach with people who aren't in the same zip code even. So it can really kind of expand the treatment discussion to patients who are much more remote physically, and then let them know whether or not it's critical, at a given stage in their treatment plan, to come to the high volume center or not. Next slide, please. Okay, so if there is no MDT available, what are the steps required to kind of establish one of these groups? Number one is identifying the team members. Dr. Pillai went over the types of physicians and non-physician caretakers or providers that are critical for these groups to function well. Obviously, this takes resources. Some administrative support and coordination is critical. Then you just have to do the work, right? Schedule the recurring meeting, discuss cases frequently, seek support from the kind of administration in the hospital and also from the community members. And of course, always maintain that the focus is on providing optimal care and the most safe types of care for patients. And hopefully this will then kind of be a very obvious value proposition in the end. Next slide, please. Okay, that being said, there are some barriers to kind of optimally running these types of MDTs. So of course, this is a medically very complex series of problems or set of problems just biologically and from a treatment therapy effect and side effect perspective. Certainly it is a resource intense way to run a program, and it requires funding, and it requires also many different types of disciplines to function optimally. So those are all kind of potential barriers, but I think, we're optimists, generally speaking, or we wouldn't take care of cancer patients, I think. And so I think these are actually opportunities to kind of improve the care for many of these patients. So I think it's a complex discipline and a complex disease, but it provides an opportunity to really come together and deliver the best possible care as a team. Next slide, please. All right, so to summarize the first part, the first main part of this talk, there are more than one way, there's more than one way to kind of forming these MDTs. Some of the most effective ways that we feel like you could do this are, number one, is to have co-located clinics where, for example, Dr. Pillai, Dr. Ahmed, and I saw the same patient this afternoon together. To have regular meetings of these MDT tumor boards to really discuss and debate the data underlying our decisions or the treatment options that we present to these patients. And then to try to expand the reach of the high volume centers into the community where they may not have access to such a kind of a broad array of specialists all at once, to try to improve outcomes for people outside our immediate reach. These approaches have been shown to improve outcomes for patients with HCC and other cancers. And given the pace of change and the complexity of these diseases, it's likely that it'll be even more important in the future. So with that, I think we're going to move on to some cases, I believe. Oh, first a question. Excuse me. So one question for the cases is, how do you think you'll use this kind of multidisciplinary HCC and biliary tract cancer care approach to improve communication and coordination in your specific practice? And we'll give you a little bit to kind of think. You can answer via a QR code.
All right, we're going to move on to the multidisciplinary tumor board. We're going to present and discuss some patient cases. We'll sort of simulate the tumor board as Dr. Francis and Pillai sort of discussed. So we'll have our first case example will be Mr. Twist. He's a 61-year-old gentleman with metabolic associated fatty liver disease and cirrhosis, Child-Pugh class B. He has undergone successful hepatitis C virus treatment. He has a low adherence to HCC surveillance, unfortunately, and has not been seen for 5 years before current follow-up. And on follow-up, he was found to have a large 6-centimeter localized nodule in segment 8. So maybe we'll start with Dr. Pillai. When you sort of see a patient like this in your clinic, what are some thoughts that you have when you sort of first intake this patient?
Thanks. Yeah, I think this is a common case. So one, I think Dr. Francis already alluded to this. Just because we treat and cure hepatitis C, if the patient has cirrhosis or very advanced fibrosis, really should continue to have surveillance. There's lots of data that shows they still have, quite a high incidence of developing liver cancer over time, like this gentleman did. So one of the first things that pops in that I look at is the fact that he's Child-Pugh class B. So we want to make sure, that's okay. We could still treat through that, but we just want to be aware of what makes him a class B, what his bilirubin is, what his albumin is. Does he have ascites? Is that what's making him class B? Does he have encephalopathy? So I think that aspect is really, really important. The good thing is it sounds like he just has a solitary nodule. So if he has good performance status, even though he's a Child-Pugh class B, we would offer treatment providing that there was nothing else, barring care.
That's great. And as sort of when you see a patient like this at this age and kind of given the comorbidities that you've talked about or all the variables that you consider, what do you think an ideal sort of destination therapy is for this patient, or what do you think, is surgery an option?
Right. I think that's a great question. So Child-Pugh B, so I'm assuming there's some portal hypertension there. So that's important because then, surgery is likely not an option. The platelets are low. If they have, ascites, so transplant, if there is no other comorbidities that are preventing it or any other psychosocial reasons preventing it, would be where I kind of think of as far as, this would be the curative ideal for this patient with Child-Pugh B, solitary lesion. It is outside Milan criteria, so it'd have to be downstage, and has portal hypertension.
Yeah, makes a lot of sense. Dr. Francis, any thoughts as an oncologist? Anything to consider here?
Yep. I think a couple points. Number one is the Child's B category. Actually all of our systemic therapy regimens, the immune therapy regimens, the anti-angiogenesis targeted therapies, they were formally studied in prospective trials with patients with better liver function than this patient, Child-Pugh class A. However, we do see a lot of Child's B patients just pragmatically in the office and what to do there. And so there is a lot of kind of real world data kind of evaluating many of the regimens we have talked about in prior sessions, but the immunotherapy regimens more recently in the Child-Pugh class B, specifically B7 and B8 setting, and showing that, well, I guess B7 versus higher than B7. And most of these studies, again, with the caveats being that they're not prospective studies, et cetera, have shown that Child-Pugh class B7 tend to do quite well in terms of their cirrhosis is not as limiting as to their overall outcome as it would be if their Child-Pugh status was higher. So that's one point. Number two is, again, if it's an unresectable tumor, then we do have level 1 evidence in general for, again, Child's A patients with unresectable disease for our medical therapy, systemic therapy. So I would say those two are 2 points. But then finally, again, if the goal is to ultimately have the destination of liver transplantation to kind of cure the patient of the cirrhosis and the cancer, then certainly local regional therapies like arterial therapies for these large tumors are certainly considerations as well.
That's great. Shall we move on to the next slide? All right. So our patients, as Dr. Francis sort of eloquently stated, has many options here. He underwent local regional therapy. And 3 months after that therapy, the primary tumor was smaller, about 5.5 centimeters. However, unfortunately, several new smaller tumors were present at distal sites within the liver. So the case was again brought to the tumor board for review. So Dr. Pillai, what are your thoughts here about just the patient's tumor and sort of response to therapy, those types of things?
Yes. So I think just first up with local regional therapy, there's so many things we can offer, right? And we often, and especially we consult you for lots of different modalities. And I think one of the things to keep in mind is not every modality is optimal. It really depends on the location of the tumor, the size, and number of tumor. So if you have smaller tumors, so ideally under 3 centimeters, you have 2 or 3 tumors like that, they're well circumscribed. You could use a microwave ablation. Of course, the most common therapy that people talk about is TACE, which of course you could use, but it is macroembolic. And if you have a portal vein thrombus, you shouldn't use TACE. And we use TACE less only because there's more and more data that shows that time to progression is quicker with TACE. So if you're trying to get to a curative resection or transplant and your patient's waiting on the list. In a patient like this, we would probably use TARE at our center, which is transarterial radiation, radioembolization. So TACE and TARE being the 2 catheter-driven therapies. I always say it really depends on institutional expertise. You certainly don't want someone to do TARE for the first time that hasn't done it, not get as good at response if they are very good at doing it TACE. Would you agree, Dr. Ahmed? That's usually what we tell people.
100%. I think you hit the high points, which is this lesion was larger than 3 centimeters. So I think that would have been the preferable approach would be microwave ablation if this was less than 3 centimeters in a favorable location. And then since it's larger, we would prefer intra-arterial therapy, whether that's TACE or TARE. And that's going to be largely driven by institutional expertise. Just like TACE, requires a certain expertise, TARE also, there's a lot of considerations in terms of dosimetry and where to dose from and things like that. So I agree with you 100%.
And the only other one that we didn't talk about is SBRT. So again, that's also very center specific, a very strong radonc program. Can also get excellent outcomes with that. Not as many studies and data, but definitely more and more data. So I think that how you determine local regional therapy is important. Who's going to do it is important. And then, so here you say the primary tumor is smaller. So the only thing that I would wonder is, did that tumor get a complete response? Is it just the cavity is smaller and it's completely dead? There's no enhancement. So that would be a win. But the fact that there's new multiple tumors, which we're going to assume are, other smaller HCCs, would give me pause as far as transplant in this patient, since that was our initial curative direction that we were going. So this is where I would probably talk to Dr. Francis to figure out what his thoughts were.
Yeah, so I think here we have, again, whether they're de novo tumors, meaning new tumors within the liver that was kind of prone to happen regardless, or metastases from the primary site. Functionally, we treat them the same way. I think medical therapy makes sense. Again, we don't have level 1 evidence guiding us as to which is the optimal therapy, especially in the child's PUB setting, but certainly many different immune therapy options, presuming there's no contraindication to immune therapy, could be used here. And I would say that for this type of case, it would still potentially lead to transplant in the future, but we certainly wouldn't want to lead in, like Dr. Pillai said, with progressive disease, because then that's likely going to lead to cancer recurrence and kind of the worst of both worlds. So a large transplant operation with lifelong immune suppression and not curing the patient of their cancer.
And I think one other thing which we didn't have here, this patient, we didn't have the AFP tumor marker. Obviously, if they were AFP producer, we would have a better idea of where we were going. But we do know, 30–40% of patients don't produce AFP, so then it's not as helpful. But yes, I completely echo. If you are going to start systemic therapy, ideally we want about 3–6 months of complete stability without new tumors if we're going to revisit transplant, which you certainly can if they're small enough.
Yeah, great points. We can move to the next case then.
I want to see if anyone has any questions.
Oh yeah, sure. If anyone has any questions, feel free to enter it in the chat or
Unmute.
unmute. Yes. I didn't know if they had the ability, but
Yeah, if there's anything you all would do differently in your programs or your practices, we'd love to hear. Okay.
all right. We'll move to the next case. This is case number 2, Ms. Flowers. She is a 64-year-old woman with history of alcoholic cirrhosis. She is, however, has better functional liver reserve. She's a Child-Pugh class A. She has been abstinent since her cirrhosis diagnosis. Almost very similarly, she also has a single nodule that measures about 6 centimeters. And as Dr. Ply mentioned, appears to be an AFP producer as a AFP level of 1,000. So maybe we can start with you again, Dr. Pillai, in terms of with that AFP in mind, is there anything, what thoughts sort of go through your mind with this and the Child-Pugh A?
Sure. I mean, so different. So Child-Pugh class A, so preserved liver function, may not have portal hypertension, even though they have cirrhosis. We didn't put here like platelets and bilirubin, things like that. And then the single nodule, I think it depends. So is it an infiltrative nodule? Is there any concern for vascular invasion, or is it like a very well-defined 6 centimeter nodule? Now, that AFP of 1,000 is important. We, for let's say that someone like this could be downstage to transplant, meaning her tumor is outside the solitary, you have to have one tumor under 5 centimeters for transplant. She's right outside that, but AFP also has to be under 500 if you're going to be listed for transplant. So either way, she would have to be downstage. I would say in our practice, if you don't have any satellite nodules, if your staging scans are clear, there's no clear macrovascular invasion, and it's a solitary nodule, the AFP of 1,000, we would probably lean towards local regional therapy, either to downstage to resection if she has no portal hypertension, it's in an area where you have good remnant liver volume afterwards, or transplant.
Yeah, great points. Dr. Francis, would there be any features of this patient? I think Dr. Ply maybe touched on some of them, but where you would say maybe in the tumor board, hey, local regional therapy is a good idea, but however, maybe systemic therapy may be a better idea, or maybe a good combination thought?
Yep. Great question. Yeah, the AFP of 1,000 really implies a high risk of occult disease, either in the midst of or already spread somewhere else that we are not aware of, right? So all of our scans have limited resolution, down to about 1 centimeter, but beyond that, smaller than that, it's very difficult to definitively rule out other kind of small micro metastases, let's say. So certainly systemic therapy could at least be discussed, probably would be discussed as an option for this patient. And then finally, you brought up the point of combined local and systemic therapy, local regional systemic therapies. In the past year or so, there have been 2 combination of TACE, transarterial chemoembolization, plus systemic therapy trials. Both of the systemic therapy components were combinations of anti-angiogenesis therapies plus immune checkpoint inhibitors. So the first one was the Emerald-2 trial. It was TACE with or without durvalumab, a PD-L1 inhibitor, and bevacizumab, an anti-VEGF-A antibody. And the addition of the medical therapy to TACE essentially doubled the progression-free survival in that study from about 8 to about 15 months. No readout of overall survival in that study yet. And then more recently at ESMO, just a couple months ago, there was the LEAP-012 trial, which was TACE with or without lenvatinib, an oral inhibitor of the kind of VEGF receptor plus other kind of related kinases, and pembrolizumab, a PD-1 inhibitor. So, and that was led to very similar prolongation of PFS, something like 10 to 14 months PFS improvement, or from 10 to 14 months, I should say. So again, no OS, no overall survival readout yet for that combination. Now the difficulty is, again, we don't do a lot of TACE, especially in this country or at high volume centers. So does that even progression-free survival benefit map to centers who use primarily radioembolization or Y90? Unclear. Those studies are ongoing. So certainly these are the types of discussions we have at our tumor board meetings.
Yeah, all great points that I mentioned. As you've noted, we're part of even some of those trials looking at combination TARE and immunotherapy for kind of similar patients who this I think would actually be an ideal potential patient for that we would discuss as well. So any other thoughts before we go to the next slide? All right, let's do it. So as a follow-up, 6 months after systemic therapy, including an immune checkpoint inhibitor, the tumor size has shrunk indeed to 5 centimeters, which is now at that threshold line that Dr. Pillai referred to with the Milan criteria. AFP is also correspondingly decreased at 300. So what do you think, Dr. Pillai? Do you think we can operate on this patient?
Yeah, I think if this patient is showing response, ideally, I would like to, it would be great it to be smaller, the AFP even better. The patient has no portal hypertension. You could resect. Sometimes in these cases, you would almost want to stop the systemic therapy just to see if there's new tumors that pop up all over the place before you do that. If we were going to go the transplant route, you would need to do that for about 3 months because you're going to wait on the list about 6 months before you get exception points, unless you have a living donor. So it really depends which direction you want to go. Are you going to resect? Is it resectable or is it transplant?
Yeah, that's all great points. Could maybe even argue to, as Dr. Francis mentioned, then now to incorporate local regional therapy potentially again with it smaller to kind of further get it, into a safer area for some sort of surgical procedure. Dr. Francis, any thoughts from your end from a systemic therapy standpoint?
Not really. I would say that certainly could, again, depending on the timing of the transplant, could continue the systemic therapy, irrespective of some of these other decisions. Sometimes we might have to, hold a dose or delay a little bit depending on what type or types of local regional therapies are being offered. We won't get into the details there today, but yeah, I think these are all good points. And this is the type of patient who we would want to try to get to some sort of definitive therapy.
Agreed, definitely. Okay, great. We can go to, let's actually pause very quickly if anyone has any questions. And feel free to, at any point, to just enter into the group chat or come off mute and interrupt us. We're happy to answer any questions. Otherwise, we'll proceed forward with our last case. This is Mr. Garvey. He's a 53-year-old male, 25-year history of Hep B, and family history of liver cancer on his mother. And 2 years ago, he had an incidental finding of a solitary lesion about 2.7 centimeters in largest dimension in the left medial segment of the liver, otherwise known as segment 4, and underwent surgical removal with hepatectomy and removal of the gallbladder, cholecystectomy. And on histology or on pathology was confirmed that this was a combination HCC and cholangiocarcinoma. And the most recent surveillance identified intrahepatic metastases, unfortunately, within segment 4 and segment 7 as well. So maybe Dr. Pillai, if you want to maybe sort of speak on, mixed HCC cholangio, how that sort of maybe sort of changes our view or approach to therapy, and then maybe touch on some of the points of this case that how you would determine how you want to proceed next.
Yeah, so I think one, this person has Hep B, so higher risk of HCC and cholangio in patients with, viral hepatitis, especially if they have cirrhosis. It is important to note that patients with hepatitis B do not need to have cirrhosis. About 20% will not have cirrhosis and they can still have HCC. So it's very important to surveil those patients early, and there's guidelines for that. It's not uncommon, though, for solitary lesion. Hep B patients are very well compensated to undergo surgical, hepatectomy. So that's great. I think the thing that is not as common is that it was a mixed tumor. So if you got tumor markers earlier, if your AFP was not as high or CA99 was higher, you could maybe have concern for that. I'm not sure if this looked like incidentally, if it looked like an HCC and then on explant is a mixed CCA, which we see that as well. There is data that if you have these small under 3 centimeter lesions that are mixed, they still do really well. So this person should have done better than they did. There is not a whole lot of data as far as mixed tumors and transplant. There are some data that shows in select patients, again, smaller tumor size, they do okay with transplant if they're not poorly differentiated tumors. They have smaller tumors if they're not multifocal. But again, previously, this should be a relative contraindication for transplant. So it really depends on that. So I guess from, and we don't really have the timeline here, it depends how far from the initial hepatectomy that they recurred and how big those lesions are. But in general, we're usually not thinking about transplant always in these patients, and probably thinking more either, local, regional, or systemic therapy, or possibly even re-resection, depending on liver function.
That makes a ton of sense. Dr. Francis, from a sort of a medical oncology side, these are mixed tumors. How do you prefer as an oncologist, or how should we be thinking about these in terms of systemic therapy options?
Yep. So after surgical resection, there is no, unfortunately, well-defined so-called adjuvant or post-operative therapy to reduce the risk of recurrence for these mixed tumors. For standard biliary tract cancer after a margin-negative resection, capecitabine, which is an oral chemotherapy pill, is a standard. After resection or ablation, I should say, as well, of hepatocellular carcinoma, HCC, for a while there, it looked like the combination of atezolizumab and bevacizumab was going to be a standard because of an interim analysis of a trial called the IMbrave 050 trial, showing a prolonged relapse-free survival benefit for that combination relative to active surveillance alone in that setting. However, subsequent analysis that was presented later showed no improvement in overall survival, and in fact, the relapse-free survival curves kind of intersected with each other after, I don't know, a year and a half or two, something like this. And so there still is no standard of care post surgery for either HCC or cholangiocarcinoma alone, and definitely not for these mixed histology tumors, which are this very rare hybrid variant of both.
Yeah, great. Thank you very much. Let's go to the next slide, C. So as Dr. Pillai mentioned, that surgery is also a potential option here. So Mr. Garvey underwent a second hepatectomy and also received gemcitabine and cisplatin. And after 2 cycles, unfortunately, another tumor recurrence with additional tumors were identified, and underwent genetic analysis of some of that tissue And there's sort of a myriad of findings here that you can see that perhaps Dr. Francis, maybe you can sort of start by explaining to us what those, sort of help, or how these help us with further management.
Sure, sure. Yeah. So the first bullet point shows the tumor mutational burden, TMB, was low, that the tumor had microsatellite instability and did not express PD-L1. So all of these are potential tumor tissue biomarkers for responsiveness to immune therapy. Now, so again, kind of examining HCC, cholangiocarcinoma, and mixed HCC cholangio, kind of what's called biphenotypic HCC or cholangio. None of these biomarkers have been shown to improve or decrease the odds of responding to the immune therapy containing regimens. And so unfortunately not useful here. These are just kind of present in these pan-tumor testing panels that we typically use. They can be predictive in other settings, but just not HCC, cholangio, or biphenotypic. Now, they also test specific mutations in certain genes, usually panels of 300 to 500 or more genes. This array of mutations is a pretty typical one for any of these tumors, especially CTNNB1, that's towards the end of the list, that's beta-catenin, one of the more commonly mutated genes in HCC. Same with PTEN, GNAQ, less. So anyway, so these findings are all kind of part of the profiles that we tend to get. Unfortunately, none of them have approved therapies that exploit those specific genomic changes. That might change in the future, though. We have trials here and certainly across the country trying to target for example, beta-catenin mutated HCC cases. That's CTNNB1, but certainly not as a standard of care option yet.
Great. Dr. Pillai, in terms of sort of next steps, your thoughts, it seems like, upfront strategy was kind of local with surgery. Would you be leaning towards now doing something more systemic because it seems to be recurring?
Yeah, absolutely. I think, clearly this is someone whose tumor is recurring and additional tumors, and we don't have any long-term stability yet, and has already had 2 resections. So I'd be really, nervous about offering another surgical options without just more stability, and not sure if they would ever honestly get to another surgical option here.
Yeah, totally agreed. For both of you, maybe any additional imaging that you would consider as further workup?
I think a PET scan would be good here for prognosis, right? Prognostication, make sure, is there things outside of the liver? It just I think it always helps to give patients like just a real clear idea and picture of life expectancy so they can plan and things that, and of course we have trials, and as long as they have good performance status and good liver function, there's many options. And I think we even tell a lot of our cholangiocarcinoma patients, Dr. Fung used to say this all the time, it's just kind of like picking out weeds, right? Like as long as you stay healthy, we can try to, continue to kind of like pull things out and live a long life. But I think you have to consider all these other things. So for me, a PET scan would be helpful. I think whenever you see something that's not very classic BI-RADS5 lesion in a patient with Hep B, getting tumor markers and getting a biopsy is really important to prognosticate, so you're not missing a cholangio or a mixed HCC cholangio.
Makes sense. Dr. Francis, maybe final thoughts?
Yeah, very tough to know what to do for this type of patient from a medical therapy perspective. Certainly lots of, kind of small case series or retrospective data sets showing, some activity of various regimens. There was a small case series from ND Anderson, one of the larger case series, I can't remember, it was like a couple dozen patients, I believe, showing that the patients who received some sort of hybrid medical regimen targeting both the cholangiocarcinoma, for example, with gemcitabine and cisplatin, like this patient got, and the HCC with immune therapy, like gemcis durvalumab or gemcis atezolizumab, that those patients seem to do better, but certainly retrospective data set confounding variables were there for sure. But I would probably move in that something like that direction. Already got GemCis, maybe give them something more HCC like, in terms of the
Mhm.
systemic therapy regimen next, unless there was a good trial option. But yeah, it's difficult to know even what statistics to quote for these patients, with response rates, these types of things, because we just don't have good measurements of them.
Yeah, absolutely. Makes a lot of sense. Relatively rare tumor to begin with, and then now we're getting into even more, sub-analysis of patient cohorts here. So, all right. Well, with that, I think we'll finish up. Any final words, Dr. Pillai, that you want to impart to the group?
No, I would just, just encourage everyone to really think about these multidisciplinary formats. I mean, this is actually really how we do our tumor boards, with maybe a few more voices added, including surgery and radonc, and but I think you can be very cordial in doing these things. It doesn't have to be, territorial or critical. I've heard that come up. What if one person wants to do this? I think if you build a team that you trust and really try to follow evidence-based, guideline-based, innovative care, as long as there's a pathway or protocol for it. It's actually probably one of my favorite things that we do is this group and our clinic within this group. And I think it's really I couldn't stress enough that I think it's really the best option for our patients. Thank you all for joining us.
Thanks so much, everyone. You can claim your CME with the QR codes on the screen. There are more meetings coming up if you want to scan the registration code as well, and I'll be emailing out the CME evaluation to everyone as well. Thank you so much.
Thank you. Bye, guys.
Thank you.
Thanks,
Good night.
everyone.
Okay, bye-bye.